So with Mrs. S, you said you're going to treat her for 3 to 6 months. So that's like the standard treatment for someone with a new clot. We think this was probably provoked, but because of her family history, we said we were going to test her. And how might you decide, like, if you test her after she's done that initial bout of anticoagulation, what would you tell her going forward based on the results of the testing? Like, how is that going to change future management?
So that's an excellent question, because I think in this patient, it's not going to really change our management of her. It may help her understand why she got a clot, and believe me, people really want to know, why did this happen to me? Why did I get a clot? As I said, it may make other providers involved in her care more aware of her risk. One thing that may be important for any children that she might have, or children that her sister has, about the risk of oral contraceptives and pregnancy and risk for clots. And people may look at that, differently, and may take alternative strategies. In this particular patient, if I find an inherited thrombophilia, it's not going to change what I do with regard to anticoagulation for this acute event. We have a clear provoking factor, and as long as she's not obese and doesn't have other things going on, I would not give her indefinite anticoagulation. I would stop. What I would do, and for which there are no guidelines available on this because there are no data, is that when she flies again, particularly if she's going to Singapore for work, or Australia or New Zealand, or even across, from Boston to California, I would give her what we call air travel prophylaxis. And I use off-label, the prophylactic dose of rivaroxaban 10 milligrams, or apixaban 2.5 milligrams every 12 hours for 2 doses, depending on how long the flight is. Now, there are lots of society guidelines on this, there are a lot of society guidelines on how to treat VTE. There are not a lot of guidelines that say anything about travel prophylaxis. The American Society Hematology guideline on treating thrombosis, treating venous thromboembolism, came out in 2018. And it said, well, if you want to use it, you could use Lovenox. And I gave the authors bunch of crap for here was your opportunity to write down what we do in practice, right? Because all of these people usually do give some sort of air travel prophylaxis, but there are no data, right? And so again, it's very hard. I think over-treating a 38-year-old woman who appears to have no bleeding risk at all, and who's already demonstrated that a long flight can lead to a thrombosis, is I think the risk-benefit analysis in my view, favors the benefits.
And you said, she might get enoxaparin, she might get the lower dose rivaroxaban, apixaban. And what does that look like? Do you tell them start it the day you travel and continue it for how long?
So I usually use one of the 10A inhibitor DOACs, and I have them take it 1 to 2 hours before they get on the plane. That's the benefit of rivaroxaban and apixaban, which are the 2 most commonly used 10A inhibitors, because they have peak onset of action within 2 to 3 hours of ingesting. Really, really fantastic. You use enoxaparin, and it's same thing, but actually the duration of effect is shorter, right? So the half-life of enoxaparin is about 6 hours, where the half-life of rivaroxaban and apixaban is more like 12. And so for most patients who are normal weight, who I think need travel prophylaxis, I'll usually have them take 1 dose, unless they have a very prolonged, like Singapore is by the time you start the travel and end the travel, it's much more than 20 hours, right?